Now, can I start my talk, please?
Yes, sir, sure.
Yeah. Say, 1 minute. My topic is bronchial asthma, a disease concerned with water. Old wine in new bottle. Now, as all of us know that bronchial asthma, though considered in past as wheeze or no wheezes, because all that glitters is not gold, all wheezers are not asthmatics, and all asthmatics are not wheezers. Now, this definition somehow this changed after some time later as paroxysmal wheezy chest. Now, again, this concept or this definition was wrong because there were many conditions which presented with paroxysmal wheezy chest. As we know, not only the bronchial asthma, but cardiac asthma, allergic bronchopulmonary aspergillosis. People have got COPD exacerbation, which presents with paroxysmal wheezy chest, and so other conditions. Tropical eosinophilia is another one. Now, this definition lacked very important concept that of inflammation. But hyperreactivity phenomenon is also important, hyperreactive phenomenon or hyperresponsive phenomenon, which is considered to be a sine qua non of bronchial asthma. Now, this condition is very important because it is related also to inflammation. And say, most of the time when the person, say, for example, is having remissions or not in having any evidence of bronchospasm, the parents, they say that, how about my child would like to develop bronchial asthma as we, the father and the mother, both are having bronchial asthma, possibility of child developing bronchial asthma. What is there? Then we have to do this non-specific test. We have been doing methylcholine exercise, but hyperreactive phenomenon can also be demonstrated with double distilled water inhalation, which I will talk a little later. Now, this condition of asthma is also defined as lack of beta-2 receptors. The lack of beta-2 receptors, in fact, most of the patients are having chronicity of bronchial asthma because of this lack of beta-2 receptors. In fact, in postmortem, they have revealed that, in fact, there is a dense population of beta-2 receptors in bronchial asthma rather than lack of beta-2 receptors. But on this autoradiographic mapping, they have found out that the beta-2 receptors are deficient, not deficient in quantity, but it is functionally a downgradation of the beta-2 receptors. Now, geno-environmental factors, again, very important. There are so many conditions, there are so many these chromosomal changes which take place in geno-environmental factors. I'll talk about a little later. The psychology is a very important concept in bronchial asthma. It is considered to be a psychosomatic disorder. I can cite some example here. One of my patients, 14, 15 years old boy who had come to be saying father was complaining that he was having bronchospasm or wheezy chest whenever he used to be in his school classroom. But he was in habit of keeping chalk piece in mouth. That was the only thing that he conveyed. I said that you come down to my OPD, outpatient department, we'll see that. And then I examined, the chest was clear, and gave him this chalk piece, and patient had very classic wheeze. I asked him next day, I gave him chalk piece order saying that I'm giving you this medicine for you. And again, the patient had relief completely. And again, third day, when I gave this antacid, the crushed gelusil tablet, saying that I'm giving you the chalk piece in powder, patient had bronchospasm very severely. Such testimonials are very often available. So one of the patients, for example, he said that, doctor, I'm 50, 60 years old male patient. He was given conventional therapy for the bronchospasms and steroid therapy, but did not improve. He was demanding all the time, doctor, give me only immunophilin, otherwise I'm going to die. So looking at the patient, whenever the doctors come nearby, the patient used to have the wheezy chest. So I said that, nurse, please provide this patient the normal saline, saying that giving aminophylline. And we had seen that immediately after giving normal saline, the patient had this relief. Such patients, psychological problems, psychosomatic disorders, sometimes may be very severe. Patients may have even suicidal tendencies in them. The hormonal and occupational factors, again, important in concept of bronchial asthma. As we see that the 1/3 of the patients pre-menstrually, the patients are having this exacerbation of bronchial asthma, 1/3 during menses and 1/3 after menses. This hormonal therapy, cyclical therapies, these manifestations are quite frequently noted. Sometimes these may be very, very, very severe. And sometimes we have to reward for the progesterone therapy for these patients. So in hypertrophy and hyperplasia is related importance, and which do not know how hypertrophy and hyperplasia is taking place. Some probably this is also genetically related problem. And many of the patients who have this hypertrophy or hyperplasia, they have chronicity of bronchial asthma. So environmental factors take birth in mother's womb only. The interaction is very important. And how do we understand that whenever we have the strong family history of allergies in family, or a strong family history of bronchial asthma, since genetic role should be considered when there is a clear history of atopy. And the first degree relatives, we find more incidence for the gene-environmental factors in them. The chromosomes regions which are defined in asthma, they are in 5q, 11q, 11q, very important for Ig production, 12q, and short term of 6p. The 5q is important for various leukotriene liberations. A distinctly matrix metalloproteinase gene, what we call as ADAMS33, is found on 20p, which is responsible probably for hyper-responsiveness or this hyperreactivity. Now, the literature surveys concepts that the disease, the definition or concept which was earlier forwarded by Skading, the disease characterized by wide variation over a short period of time in the resistance to flow of air in intrapulmonary airways. This is how asthma was defined earlier. Now, each component of this definition is very important, as the wide variation means it can be mild, it can be moderate, it can be severe. Over a short period of time, that means it is reversible, partly reversible, completely reversible, spontaneously, or after giving some therapy. In resistance to flow of air in intrapulmonary airways, that means it is not the big trachea and the bronchi, it is called bronchi, which are responsible target organ in bronchial asthma. So this concept was changed somehow after a decade or so. And in 1995, the National Heart, Lung, and Blood Institute added for the first time that it is chronic inflammatory disorders, bronchial asthma, and rest of the things were well maintained. That is recurrent wheezy chest, variable airflow limitations, which is reversible, and underlying cellular and biochemical pathology remains same. The inflammatory disorders, inflammatory cells are mast cells, eosinophils, T lymphocytes, and they are disintegrated. The 12 years separates these two descriptions, but definition of the disease dependent on current state of clinical and scientific knowledge. At the as the understanding of the process deepens, the defining characteristic changes, the definition of one time. But whatever has been conveyed in past even remains true even today. And therefore, we say that hierarchy is in the disease exists and definition exists. Now, asthma is considered something like love, concept of love. The physicians, they think about wheezy chest. Physiologists, they think about reversible bronchial constriction. And pathologists, they think about edema, inflammation, and bronchospasm. But everybody understands what is bronchial asthma. And therefore, this important aspect in this is inflammation. And inflammation and hyper-responsiveness that is combined together. The remodeling changes take place, epithelial damage and fibrosis, muscle hyperplasia, that is responsible for hypertrophy and hyper proliferation of the cells. Some of the patients, they develop proximal changes. Some of the patients, they develop distal changes. We do not know in a case which patient going to have either proximal hypertrophy or hyperplasia or distal one. Now, inflammation, very important aspect is a neuroinflammation where there is release of tachykinase. That substance P and neurokinase from C fibers. And if you have, say, anti-tachykinase or anti-neurokinase, we probably get bronchial asthma. The GID and sinusitis is also important. The most patients, those who are having micro aspirations, they have the vagal mediated reflex, esophagobronchial reflex, or rhinobronchial reflex. Now, 70 to 90% of the asthmatics, they have GRD. And H. pylori infection is seen in GRD around 30 to 90% of cases. So if we treat even H. pylori infection and inflammation of esophagus, the esophagobronchial reflex is abated, and probably this helps in management of bronchial asthma. Similarly, rhinosinusitis. If we usually say that the ENT surgeon must look down for the chest, and chest physician must look up for the evidence of sinusitis and rhinosinusitis. Now, focus my point is on the water content and water attention and bronchial asthma. Mostly, we gather this information from asthma symptoms. Hospitalizations come with patients coming with the wheezy chest and their emergency visits, which are very highest in rainy and winter season in India. Humid air, heavier, and it's harder to breathe. Humid air is they harbor fungus and mites, dermatophagites, farini, and pterygoids, and many kinds of molds. And air tends to be drier in winter months, and persons, they exhale mist. So the colder the air, the less water it can hold, and that damages mucous membrane lining and predisposes viral and bacterial infections. Remember, hot, humid climate, high, humid, and low temperature, rainy seasons, thunders, storms, they are all contributors to bronchial asthma. When humidity above and below, if it is below 30 and 50, it should be between 30 and 40. Otherwise, it triggers asthma. Each 10% rise in humidity, one additional emergency visits of asthmatics beyond hospital average of 35 takes place. And when every 10-degree rise in temperature, that results in 2 additional asthma emergency visits. And therefore, rise in temperature activates vagal bronchopulmonary C fibers, which thermosensory transient receptor potential, which we call TRPV1. There are many types of these TRPs, and sensitivity of the lung and nociceptors mediated by TRP have been studied widely, and there are around 28 and 7 subfamilies and several subunits are described. TRPA1, V1, V2, V3, V4, but important one is TRP1 and 4. and TRPM8 probably is related to humidity. Otherwise, rest, they maintain temperature. But temperature and humidity go hand in hand. Pro-inflammatory mediators and activators desensitize TRP1 channels, and the responsibility is because of cough and prostaglandins and bradykinin released. Now, asthma-water relationship best also can be understood better with observation. In asthmatics, BAL, returnable fluid is less than in non-asthmatics. If we 100 cc, if we put in tracheobronchial tree for washing and sort of taking saline drainage, 40 to 60% is returnable in normal. The same degree of obstruction in COPD retains fluid 30 to 50%. But in asthma, it is 10% only. But that means most of the fluid is retained in the mucous membrane, which acts as a sponge. And asthmatics also drink more water than non-asthmatics. That is another observation. It is also seen that the persons, those who are walkers or they are runners, exercise-induced asthma is a problem. When they stop running, they develop bronchospasm. As long as they run, they keep on running. They don't have, because the sympathetic activity is more than, but variation in temperature and humidity, they're responsible for these problems. And airway cooling is important for the development of bronchial asthma. These are the gold winners in Olympics, Amin and Jackie. Now, one study was done by us some time back with humidity, temperature, and rainfall. And we mapped the pollen amount in the atmosphere. In rainy season, we found that when August and September, when the humidity was also more, the more incidence of Amaranthus, Azadirachta, Cassia, Lanata, and Parthenium. Parthenium is neem. The possible mechanisms over here is based on osmotic pressure of the membrane and the increased space between mucosal cells and number of holes in the surface mucosa. And therefore, there is increased absorptive surface of the mucous membrane. This mucosa in asthmatics acts as a sponge that imbibes more water, leading to swelling of mucosa and increased bronchial resistance. And this defect is probably inherited one. The antigens from this external environment stick to the surface, then more amount of antigen goes inside and leads to bronchial inflammation, and this chronicity then develops. The bronchial challenge in asthmatics was studied. We did double distilled water inhalation challenge test in some of the patients. Osmolarity of distilled water is supposed to be 0, and osmolarity of normal saline is 290. And increased permeability of mucosa due to increased osmopressure is only to water and not to any other large molecule. So we had the study reviewed with 22 normal subjects, 22 chronic stable asthma, 20 chronic bronchitis, and 7 tropical eosinophilia cases, where we use this Jigger APC system with mist size of 0.5 to 7 micron, with compression pressure of 20 psi and provocative dose of PD20 FEV1 taken as 120 nebulizations at a setting of 0.6 second nebulization. Our observations was that in normal subjects, none of the patients had shown either to normal saline or distilled water any fall in FEV1. Similarly, in chronic stable cases, 22 chronic stable asthma patients, we had this fall in distilled water inhalation, post-distilled water inhalation, FEV1 in most of the patients, practically all. And chronic bronchitis, we had hardly any fall of FEV1. In tropical eosinophilia, again, we had an FE1 after normal saline and distilled water challenge was done, and none has shown fall in more than 20% here. Asthmatic patients are exclusively sensitive to changes in osmolality within the respiratory tract. Double distilled water inhalation challenge test separates asthmatic wheezers from non-asthmatic wheezers and confirms the diagnosis of asthma made clinically. And methodology is helpful for delineating asthmatic states and may define future asthma in future. For example, the child is not having asthma today, but likely possibility if he is having or not having, this test can be non-specific. Test can be performed and we can demonstrate asthmatic status. Test is helpful to identify workers who are at greatest risk while working in occupation. Simple, safe, sensitive, and is cost effective. Now, similarly, furosemide inhalation was also tried. The exact mechanism, inhalational furosemide. Exact mechanism of action, of course, is not known, but high concentration in airways that act through chloride channels of many airway cells, altering ionic and osmotic environment, calcium and sodium of the cell interferes with the bronchoconstriction. Here we had taken about 40 cases, and out of which the 33 cases had shown no change after giving this. There was no fall of weak expiratory flow rate, and in only 7 cases we had this increase in the peak expiratory flow rate, and there was no increase in 33%. That means it has given protection to the patient. There is significant protective effect of furosemide in non-specific with this double distilled water inhalation challenge test. 33 out of 40 cases showed protection, and 7 cases had no protection. Drug as a nebulizer has a promising future for its prophylactic and therapeutic role in management of asthma. Some time back, in even COVID-19 patients, also these trials were done in some patients. Probably TRP4 participates in this transaction of osmotic stimuli in different tissues, including bronchial asthma. The roster fluid shift is also an important factor because fluid shift enhances blood volume, pressure in bronchial circulation, more in asthmatics, but not in healthy individuals. And this created pressure gradient leads to air wall edema, bronchoconstriction, and one of the important causes of noxious bronchial asthma. Women have no more problem because bronchi size is less. There is a peribronchial coughing, and probably this phenomenon also leads to hyperresponsiveness in them. So in nutshell, clinical, meteorological, and experimental evidences support the theory that asthma is a specific disease with defect in permeability of mucosa to water. Defect probably is inherited. And studies connecting genetics to monitoring of the environment with regard to natural history, climatic condition, and asthma would create opportunities for understanding disease mechanisms and factors that determine what is their chronicity and severity in them. Weather conditions should be included whenever we are having consideration for management plans for asthma. The strategies should also be based on the regulation of channels. We should consider TRP channels promising target for disease therapy. Outdoor exercises be discouraged for asthmatics during period of extreme temperature, as well as during periods of high humidity. Avoid exercise as well as low humidity combined with low temperature. I conclude here. Thank you very much.
Yeah, there were some network issues. Thank you, Dr. Talib, sir. That was very informative presentation.